Okay, it's 7 o'clock and we could get started. Hi, this is the Musella Foundation's Brain Tumor Awareness Month webinar series. Today's special guest is Dr. Andrew Brenner from the University of Texas Health Science Center at San Antonio Mays Cancer Center. And the topic is a promising new radiotherapy for recurrent glioblastoma. Take it away.
Thank you. It's a pleasure to be with you all. Whenever I talk about clinical trials, I always like to start off with why clinical trials are important real briefly. Clinical trials are important to translate the results of our basic science, like what I'm going to show you here, into better ways to prevent, diagnose, or treat cancer. And the more people that take part, the faster we can answer critical research questions and find better treatments and ways to prevent cancer. And that's critically important. This is one of my patients, Ron, who came to me after having recurrence of glioblastoma, went on a therapeutic VB111 in phase 2 clinical trial, and is 5 years out from that treatment with no evidence of recurrence. Unfortunately, despite the number of clinical trials that we have, only 3% of US adults with cancer participate in clinical trials. So obviously we need to do more. This is another one of my patients here, Tara. Tara had a glioblastoma during her final month of pregnancy and had a craniotomy and a C-section at the same time. And a few months after having her radiation and chemotherapy complete, she had a recurrence and went on a clinical trial with a dual VEGF and c-MET inhibitor, which gave her about 6 more years of life and ability for her to get to know her son and her new son to be able to get to know her. So whenever we talk about brain tumors, I always like to kind of give a little bit of background about what's going on in the brain. We have a number of different cell types. Everybody thinks of neurons, obviously, when they think of the brain, but they need a supporting cast of characters. And that includes the astrocyte, which is that red cell that you see there with all the branching arms, the oligodendrocyte, which is in the bottom right corner there, which is reaching out and wrapping out its arms all around the neurons to help insulate them. And then the little brushy-like cells which line the surfaces of the brain, called the ependymal cells. These are a few of the different cells that can develop into cancer. The most common is from the astrocytes, and they have very important roles in terms of helping neurons to form connections, cleaning up any debris from an injury, helping to form the blood-brain barrier, and keeping things from getting into the brain that aren't supposed to be there. When they grow uncontrolled, that's called an astrocytoma, which there's 4 grades, and glioblastoma is the highest grade. Because these cells have these very important functions and are able to make their way around the brain, when they grow uncontrolled, it's uncontrolled growth with the ability to spread throughout the brain. So obviously that's a significant problem for us. So why do we need new treatments? Well, for the indication that I'm going to talk about today, glioblastoma, current treatments do not result in a cure. And once the tumors are cured, we do not have any FDA-approved treatments that actually improve how long a patient will live. They can impact the time to regrowth, but not how long they survive. And the best available treatments, once these tumors recur after conventional radiation and chemotherapy, only result in a delay of growth from 1.5 months with a typical chemotherapy used lomustine to approximately 4.5 months with Avastin. And even when patients respond, this tends to last only around 6 months on average. So we obviously need to do better for these patients. So why interest in a new type of radiation therapy? Well, if you look back to some of our older studies where we looked at the addition of radiation to best supportive care, or what we now know were ineffective chemotherapies, you can see the best supportive care in A and chemotherapy in B. And then when we added radiotherapy in C and D, we doubled patient survival. And then what we've seen over the years is a drift where radiation has even made more of an impact. So it's doubled again to, on average, increasing patients' lifespan by around 12 months. And so even though we have chemotherapy, which adds about, on average, for the average patient, about 2 or 3 months, and then tumor treatment fields, which adds another 2 or 3 months, it's really radiation has made the biggest dent in terms of how long people live. So why is it that we can't do more with the radiation that we have? Well, we're using something called external beam radiation therapy, and that's photons or X-rays. and pretty much pure energy, and that passes directly through the surrounding normal brain to reach its target. So the real limitation is that the surrounding normal brain's toxicity from that treatment. So as we try and go up to higher doses, and we manage to have a dose escalation in little small increments, where we're currently giving 60 gray, we may be able to give 75 or 80 gray. That is about as much as we can get without causing significant toxicity. Well, if we have a treatment that can work from the inside out and doesn't really expose the surrounding normal brain, we can really increase our therapeutic window. In other words, we can increase the amount that we can give without causing toxicity to the surrounding tissues, and that's what we aim to do. We developed at our cancer center a specific type of radiation which is able to trap radiation within the tissue. This is called Rhenium NanoLiposomes. So what we've done is developed these little liposomes that are about 126 nanometers. They're about 1/1000th the size of a cell. And they are made up of the same constituents as the cell walls themselves, which is basically lipid and cholesterol. So they're biological materials that your body is very similar to, but then we can trap within them radiation particles. And we use different types of radiation particles in this typical external beam radiation. These are what we call beta particles. And these beta particles are only able to travel short distances, and they can be very well controlled if we can get them delivered to the tissues. We're using a radioisotope called Rhenium-186. It's one of the rarest elements in Earth. It's very stable. It doesn't interact with a lot of things. It's also heat resistant and very dense. And that's why they use it as a component in alloys to make metals, for example, in jet engine blades. We generate Rhenium-186 with a reactor by bombarding aluminum. And that generates the 186 rhenium that is able to give off these beta particles that only travel about 2 millimeters. It has about a 96-hour half-life, so it just lasts for about 4 days. And then it's easily imaged due to that every 1 out of 10 decays, every 1 out of 10 times that it shoots off some particles, there's a gamma associated with it. Now that gamma is not like the photons in external beam radiation. It's not of high enough energy to cause any damage to the tissues, but it is enough that we can image it with our standard imaging equipment that is readily available in the hospital. And rhenium is a widely used isotope. It's been used in medicine procedures, about 20,000 procedures annually worldwide, although not for brain tumors. It's used for example, a skeletal metastases and other things like that. Now, other people have tried to encapsulate radiotherapeutics, but they weren't able to do a very good job of it. In other words, they could get some in there, but it wasn't dense enough so that you could get very high levels of exposure like we are able to get. And the way that we've accomplished this by making this custom molecule called BMEDA. And BMEDA is able, it has at 1 pH, when you have a very low pH, it basically is able to trap the rhenium in it, and it doesn't have any charge, and that allows it to move inside of the liposomes. But we have a change in pH inside of the liposome so that it regains its charge. And once it regains its charge, it's no longer able to move through the wall of the liposome, and it's stuck there. So this carries our rhenium into the liposome. And what we know is that if you inject Rhenium-186 directly into the tissues, it rapidly moves out. You'll lose it within a few hours. It's all gone. And then also it kind of just really doesn't spread. It kind of sticks in one little spot. But when we put it into liposomes, it stays there not for hours, but days, and it's retained very well within the tissue. And on top of that, because we change the size of the particles going from the small molecule to these larger liposomes, we're able to better separate it out throughout the tissue, better disperse it when we inject it into the tissues. And when we went into our animal models and we injected rats with a glioblastoma cell line and we treated them, what we found is there really was no maximum dose. We saw the animals lived significantly longer when we got above around 100 gray, which is a little bit more than what we give with external beam. But at the highest doses, they were living very long. We had to sacrifice one due to a rash, but it wasn't related to the treatment, and all the others did very well. And when we looked at survival in these animal models, and we treated them here and looked by whether or not in a U87 model, which is one type of GBM animal tumor, that the animals would readily die off by around 50 to 60 days. There wouldn't be any left. But when we treated them with Rhenium 186, we saw the animals living very long. And a matter of fact, when we analyzed these tumors, these brains from these rats here, we saw no evidence of any residual tumor. They were all alive and doing well until we sacrificed them, and there was no obvious evidence of injury from the treatment either. And when we looked in a more aggressive U251 model, which dies much quicker, we saw the same thing. Most of the animals were living very long. When we looked by MRI, this is the brain here, and you can see on day -1, the tumors are about the same. And about 14 days later, the tumor is able to grow to almost completely fill 1/2 of the brain. And the rhenium-treated animals, 14 days after treatment, there's very little remaining, and it eventually just disappeared, which is what we saw when we sacrificed the animals. There was no residual tumor there. Now, when we look in other types of cancers, leptomeningeal carcinomatosis, which is where cancer cells are growing in the spinal fluid, and we inject those animals, we're able to see that we're able to give very tremendous amounts of doses, about 20 to 30 times what we have been able to give with external beam radiation. So both with GBM and leptomeningeal models, we were able to achieve doses of around 2,000 gray. So keep that in mind. When we give patients external beam radiation, we're usually talking about 60 gray. So here we're getting up to 2,000 gray, which is about 30 times as much radiation without any toxicity in the animals. So we needed to evaluate this into something more realistic in terms of closer to humans. And so the FDA recommends we use a dog model. So me and my partners took the Rhenium NanoLiposomes and the catheters that we plan to use to treat patients. And we took them up to Michigan to a facility there, and we injected into dog brains and looked to see if there was any toxicity there or any problems associated with the radiation treatment. And in fact, what we found is that no matter what dose we gave, going all the way up to 360 gray, there was really no significant changes. The only thing that the pathologist could see was the place where the catheter was placed, but no effect of the radiation itself in terms of the normal healthy tissue of the brain. So after getting the approval from the Food and Drug Administration to test in humans, we started with what's called a phase 1 study. And this is our very first patient. And you can see on this co-registered image, we use this software called iPlanFlow. And you can see the cavity where the tumor was before. And you can see right above it, and this is the top of the patient's head, over here, the back of the head. You can see right above the cavity, there's a regrowth of tumor. So we made our treatment plan where we were going to place the catheter directly into the tumor right above and inject this area of tumor regrowth. And we can actually plan this in silico. In other words, all the planning is done on the computer in terms of also the treatment and where the treatment liposomes will go. And this is another three-dimensional example. This is actually the patient's image overlaid with our treatment plan. We can also map out his vision neurons to see where his vision was in relation to the area we're treating to prevent any damage to his vision. And then this is the setup in the operating room. This is what's called a brain lab workstation that we use. This is a Vario guide, and it helps us within a millimeter place the catheter in exactly the spot where we want. This is our first patient after his catheter was placed. So we do a biopsy right before we place the catheter, confirm the recurrence of the tumor. Then we drop the catheter through the same hole, placing the catheter down into the tumor using the treatment plan that we generated. And then we use this little bolt to hold it in place, and the catheter comes right out. And the patient wakes up and he can go to his room and have dinner or watch TV. And the next morning he goes down to the nuclear medicine suite where we can actually live image the administration of the radiation. So this is the 40 minutes into the treatment. You can see this bright signal here is the radiation being emitting from the area where we injected it. 6 hours afterwards, you can see the radiation covering the tumor here. It stays there even 24 hours later, and we even have imaging going out to 10 days now. So this patient had very good retention of the radiation in his tumor. About 96% of the amount of administered radiation was retained all the way out to 3 days. And the amount of radiation absorbed to the tumor volume was 143 gray. In other words, more than twice of what we would expect with external beam radiation. And this is in a recurrent tumor. And the patient tolerated it really well. He was kind of amazed because his initial radiation with photons took 6 weeks. This happened all within the course of 1 day, and the next day his catheter was pulled out and his radiation was done. He had a little bit of scalp irritation, a little bit of discomfort from the incision site, but we slide the catheter right out and staple it back up. This is our second patient. He had a recurrence again in the right next to the surgical cavity. You can see it better over here. So this is the surgical cavity here. We map out the tumor recurrence right there. You can see this is the forehead here, the back of the head. There's the recurrence right there behind the tumor. Behind the resection cavity. And you can see that the approach we took to target the tumor, this is where the catheter would go. And then you can see his radiation. At the end of infusion, all of the Rhenium NanoLiposomes are covering the tumor area. 24 hours later, we get a little bit of radiation up towards the cavity, but almost all of it is retained beautifully within the area of the tumor. And this is 8 days later, still being retained in the area of the tumor. And then we could follow this patient's tumor, and you can see the area of radiation compared to what happened with his tumor. And this is even better view. We use something called the tumor response assessment maps. And what we can do is we can look at the contrast that is given both immediately about 3 to 5 minutes after it's given, and then about an hour and a half later. And if the contrast is retained in the tissue an hour and a half later, we know that's not viable tissue anymore, that's just dead junk, not real tumor. And if it's there at the beginning but clears out, we know that's real tumor. So whatever is in blue is actual tumor, and whatever is in red is just empty space or dead junk. And we see over time that from June through September, the loss of all that blue signal where it just turns to red. And then he had a little bit of blood accumulate in that area, but the viable tumor was gone. So he had no apparent clearance of the radiation during the first 72 hours. The retention was about 73% from 0 to 192 hours. The amount of radiation to the tumor volume was much higher than we got with the first patient. It was around 396 gray, almost 400 gray. Again, keeping in mind 60 gray is what we give with traditional radiation. And then he had no adverse effects. This is our patient 14, one of our more recent patients. And I'm not showing you his catheter placement, but I do want to show you his long-term follow-up. This was his pre-treatment tumor, 1 month post and 2 months post, and we see the radiation volume covering the entire tumor on all of these images going out. And what we see when we followed his tumor over time is that initially a little bit of kind of a slight increase by around May from January, about 4 months, but you can see it looks different. It doesn't look like that very well-defined tumor that we have here. And this is kind of what's consistent with radiation necrosis, and that's what the TRAM maps supported. And so when we followed him out all the way up to January 6th of 20, which is a year later, it had a significantly reduced in size again. Decrease in size of his tumor. And then we're able to map this. We're generating new algorithms of how to administer this, and we can monitor how the treatment goes over time so that we can better plan for patients in the future as we get more data. So to date, we've treated 13 patients. We've given up to 13.4 millicuries for a treatment volume of 16 milliliters. So we're increasing the size of the tumors we're treating. We're increasing the amount of radiation that we're giving. We've had absorbed doses as high as 534 gray, which is approaching about tenfold what we give with standard radiation. And we're not seeing any treatment-related toxicities. There's not been any significant issues in terms of patients tolerating these higher doses, because it's fundamentally much different than the typical photons we give that have to pass through the normal brain. Everything is being concentrated within the tumor itself. And so we feel like RNL has Rhenium NanoLiposomes has promise for primary brain tumors. We know it has excellent retention by the tumor from the patients that we treated so far, and it can be imaged during the treatment, allowing us to perform quality control and refinement of our methods. We have early signals of efficacy. We've had our first 2 patients survival of greater than 2 years, and we're seeing, as that last patient I showed you, patients without regrowth beyond 1 year. So it's very promising, and with that, we received funding from the National Cancer Institute, and UT Southwestern is going to be open within the next few weeks, and we'll be able to treat patients in Dallas, and we're going to be adding MD Anderson as a site soon thereafter. And so the plans are really to find the dose for phase 2. We think we're close. We don't know how much higher we'll be going, but we'll have to see. But we think we're really close to moving forward to our phase 2 portion of the study. And then we have the help of Plus Therapeutics, who has licensed this, and their involvement will allow us to expand the study to allow patients to quickly begin treatment and transition to a registration study with the FDA, where the FDA can consider this as a potential treatment for everybody with primary brain tumors, especially glioblastoma. And so with that, I'd like to say thank you to our patients. Obviously, without patient participation, none of this science could move forward. And our patients have been inspiring to us. And so we do want to acknowledge them. And then this has been a large effort, a number of different investigators, both within our own institution, as well as collaborators across the internationally, both here in the US and Israel, Austria, and Germany. And then funding from the Cancer Prevention Research Institute of Texas, the Kolitz family, which sponsors my research, the National Cancer Institute. And anybody that's interested in the study can contact our new patient coordinator at Goodwin, and her contact information is there. And with that, I'll stop. Thank you.
Thank you. That was very interesting. We just have a couple questions. You said the half-life is 96 hours, right?
That's right.
So you need the, what machine makes it? Is it a cyclotron?
No, so we generate it off of a nuclear reactor. So
nuclear reactor.
Yes. There is another form of this called the Rhenium 188. It's very similar to Rhenium 186, and it could be generated off of a benchtop device.
Okay, so in general, this is not something that could be done at any hospital. It has to be done at one of these major centers that has these devices.
No, actually, so the radioisotope is shipped to us, and we do the radio labeling within our facility, and so we can ship it anywhere. UT Southwestern and MD Anderson, they'll be receiving ready-to-use drug directly from our institution. And probably within a year, we hope that we'll have a central manufacturing laboratory with help of Plus Therapeutics. So it could be administered anywhere in the country, perhaps anywhere in the world. It's just that we have to make enough to anticipate the decay, so that the amount of dose that's given at the time would be predetermined.
It's a brilliant concept of how you get the stuff to stay inside the liposomes. But are the liposomes themselves targeted to tumor at all, or they're just controlled by diffusion?
You know, they're yes and no. So it's possible to label liposomes, but one thing we know is that astrocytes and glioblastoma cells themselves are actually phagocytic. In other words, they ingest particles, and they actually will ingest these liposomes. So it's not totally targeted, but we're not sure that that's needed because, number one, there's a huge differential between the normal cells toxicity from beta radiation and tumor cells. And then we believe that there's an actual uptake of these by the tumor cells.
Okay. And for this, would you just do that one shot of the liposomes and then no further treatments, or would you combine it with other treatments after, after they recover from the procedure?
So for this first study, because of the way that phase 1 trials work, we're only allowing a single treatment. But once we reach the phase 2 dose, our intent is to allow patients to receive a subsequent treatment. So if they've had one spot and then they have regrowth somewhere else, we can go back and treat that second spot. However, there's no reason once if we see efficacy with this, that it couldn't be later combined with other therapies. And in fact, we can actually encapsulate other compounds together with the radiation. We've actually in our laboratory been doing things like doxorubicin, where we co-incorporate doxorubicin into it. So we give both chemotherapy as well as radiation at the same time.
That's
Now,
very interesting.
not in our current trial, but that is something that could be done in the future.
Very interesting. Have you seen a lot of edema?
Surprisingly, no. We have seen edema, but it's always hard to differentiate what's tumor edema versus radiation edema. As of yet, there hasn't been a lot of that has been attributed to the drug. So nothing greater than grade 1.
Okay. What is the effect on healthy cells in the area of the tumor? Like the way I picture this, the tumor is not just one ball by itself. It infiltrates normal tissue, right?
Yeah, that's true. And so that we need to completely define in terms of what's the maximum amount that normal tissue can tolerate. I don't think that's well known. Most of the radiobiology, most of what we know in terms of tolerances are based on photon therapy. And beta is much different. You have to remember that beta is actually a particle. It has mass. And it's not just pure energy like X-rays or photons are. So the concept in terms of the DNA repair and the tolerances of normal tissue is much different than photons. But we think that there's a much higher tolerance of normal than for photons, and that the resistance mechanisms for resistance to photon radiation are different with beta.
Okay. This might be the last question. How would this compare to gamma tile? Are you familiar with gamma tiles?
I am, and gamma is essentially gamma radiation, but it's embedded within a kind of cellulose type of solid. And so gamma tiles can be placed into a cavity or around it, but they don't infuse into the tissue. And they're not betas, they're photons. So they're more similar to external beam radiation than to. So different type of radiation. This is actually infused into the tissue, whereas the gamma tiles would go within a cavity and radiate from that cavity out. So some differences both in terms of the type of radiation as well as how it's administered. This is within the tissues itself.
Okay, that's about all the questions that we had. It was a very interesting presentation. Thank you very much. Next week, we're going to have new technologies to take the guesswork out of brain tumor surgery, which should be an interesting topic. And we'll see you guys next week. And thank you very much, Dr. Brenner.